Hello, my name is James Hartsfield, and this is my video for the abdomen assessment. A quick scan of the room. Okay. All right. Now, initially, I would have the patient ask the patient to lie down supine. In this case, the patient already is. The examination begins with inspection. I would watch for rise and fall of the chest with breathing, just to note any asymmetry, any sort of visible peristalsis, any sort of visible bulges, masses, anything of that nature. I would then ask the patient, please lift your head up slightly with your hands at your sides. By doing this, any bulges, any hernias, any masses that were not observable when they're simply supine will become observable, or should become observable when they lift their head up.
Don't put my head down.
Take your head back. Thank you. And now, please take a deep breath and hold it. By doing this, again, any bulges that weren't observable beforehand may be pushed up to the surface by holding your breath. You can let your breath out. Next, I'll auscultate all four quadrants, beginning with the left upper quadrant. I'm listening for active bowel sounds. There should be anywhere between 5 to 35 bowel sounds a minute in an active, healthy bowel. Be listening for any sort of hypoactive or absent bowel sounds indicating an obstruction or some sort of mass. Also hyperactive bowel sounds, which could indicate some sort of a GI issue, such as diarrhea, upset stomach, etc. I also auscultate the abdominal aorta, listening for any sort of adventitious sounds, any sort of bruits, anything that would indicate an issue with blood flow or an aortic aneurysm. Next will be the percussion, starting again with the left upper quadrant. I percuss all four quadrants, listening for differences between dullness, resonance, and tympany, which indicates either a mass that shouldn't be there, or just an organ, like the spleen or the liver, versus empty space or open, hollow intestinal space. Or in the case of the stomach, you will hear, since it should be empty, or will be more empty than the other organs, you will hear a more hollow sound as opposed to the dullness of, say, the spleen or the liver. Continuing with percussion, I will now percuss the liver borders, beginning at the midclavicular line and working my way up, listening for change to a more dull sound, and then from the midclavicular line working my way down, also listening for dullness. I then move over slightly, closer to the axillary line, and work my way up and down, and then measure the span. The span in a healthy liver should be approximately 6 to 12 centimeters. Anything more than that could indicate an enlarged liver, where there's cirrhosis or hepatitis. It could also indicate displacement of the liver if there's some sort of lung issue or some sort of obstruction or fluid issue. I will percuss for splenic dullness, again, over on the left, near the mid-axillary line. You will hear some slight dullness when you hear the spleen versus the more hollow sound of the empty space in the interstitial tissue. So, I also, the gastric bubble, listening around the epigastric area. For the gastric bubble, there should be a difference in sound, because you're actually percussing fluid and the air of the bubble versus the interstitial fluid. Moving backwards, I did forget one thing. on the inspection, and that is the venous flow from the umbilicus and working my way out. I basically just milk in 6 different areas, the veins. And again, in a real examination, this patient would be topless, or at least have their shirt pulled up. I would milk the veins just to determine where the flow, to make sure that the flow of the blood goes where it's supposed to. Alright, moving on to light palpation. For light palpation, simply palpate no more than 1 centimeter down in all 4 quadrants. For this, essentially, you are looking for any sort of tenderness, rebound tenderness, especially in like the right lower quadrant, for instance, would indicate appendicitis. Any sort of tenderness in the other areas could indicate inflammation or infection of the organs of that area. Now, moving on to deep palpation. First, palpate the liver. For this, I'll go around to the other side. Essentially, working my way, I hook my hands under the rib cage, looking for the liver border. It should be in the upper right-hand quadrant.
On my liver?
Moving over, looking for the pancreas. The pancreas will be on the lateral edge of the rectus abdominis muscle if it's palpable, if you can feel it. Most times you will not be able to feel it. If you can feel it, it could be a cause for concern, because that could indicate an inflammation of the gallbladder or gallstones, something of that nature. Moving over to the spleen. With my left hand, I will hook under the axillary line to push the spleen up, and with my right hand, press down to feel for the splenic edges. Moving on to the kidneys, I will be using the capture the kidney method. So with both hands, I will pinch the side near the right flank and then slowly release. And as the fluid moves back, to see if I can feel the kidney. Now, the kidney may not always, again, much like the gallbladder, you may not always feel the kidney. If you can, sometimes in very thin or malnourished patients, or if there's some sort of inflammatory issue, you may be able to feel the kidney easier than in other patients. Slowly release. Lastly, I will simply, on bilateral sides of the abdominal aorta, slowly pinch and move my way up. Again, feeling for any inflammation, any sort of hyperactive pulse, any sort of bounding pulse, anything that may indicate a blood flow with the aorta. Lastly, I have the patient sit up. Please sit up. And on bilateral sides, at the costal vertebral angle, or yes, the intercostal vertebral angle, I'm going to lightly palpate, and what I'm searching for is any sort of renal tenderness. The patient should feel this as a thud, but it should not be painful with the level that I'm doing it. If it is painful, again, this could indicate in some sort of renal inflammatory issue, a UTI that has worked its way up into the actual nephrons, and it would be cause for further examination. This concludes the abdominal examination. Thank you very much.